When you ask a patient to take a deep breath, have you ever wondered how much air is actually moving? Why can a patient with severe COPD have lungs that look huge on a chest x-ray yet still be breathless? Why does a patient with ARDS have tiny functional lungs despite having anatomically normal-sized lungs? The answers lie in understanding lung volumes and capacities. These numbers are not just for physiology exams. They explain spirometry, restrictive lung disease, obstructive lung disease, mechanical ventilation, and even why some patients fail extubation. Today, we are going to build the respiratory system from the ground up. The lungs are never completely empty. This is the first concept students often miss. Many people imagine breathing as filling and emptying a balloon. The lungs don't work like that. Even after maximal expiration, a significant amount of air remains trapped inside the lungs. This residual air is essential because without it, the alveoli would repeatedly collapse and gas exchange would become extremely inefficient. To understand this better, physiologists divide lung volumes into 4 basic volumes. The first and most important is tidal volume. Tidal volume is the amount of air inspired or expired during a normal quiet breath. In a healthy adult, this is approximately 500 millimeters. Interestingly, not all of this air participates in gas exchange. About 150 millimeters remains within the conducting airways, known as anatomical dead space. This means only around 350 millimeters reaches the alveoli with each breath. Immediately, you can appreciate why rapid shallow breathing is inefficient. If a patient takes a very small breath, a larger portion of each breath is wasted in dead space. The second volume is inspiratory reserve volume. After taking a normal breath, you can still inhale much more air if asked to take a deep breath. That extra air is called the inspiratory reserve volume. In most adults, this is approximately 3 liters. This represents the respiratory system's reserve during exercise or physiological stress. Think about a patient running from danger or climbing stairs. Their increased oxygen demand is met partly by recruiting this inspiratory reserve. The third volume is expiratory reserve volume. After a normal exhalation, you can still forcefully blow out additional air. This extra amount is called the expiratory reserve volume. It typically measures around 1 to 1.2 liters. This reserve becomes clinically important in obstructive diseases where expiration is impaired. Finally, we have residual volume. This is the air remaining inside the lungs after maximum forced expiration. No matter how hard you try, you cannot exhale this volume. In healthy adults, it is approximately 1.2 liters. Residual volume exists because small airways close before the lungs can completely empty. Without residual volume, alveoli would collapse repeatedly after each breath, greatly increasing the work of breathing. Now, let's move from volumes to capacities. Capacities are simply combinations of 2 or more volumes. The first is inspiratory capacity. Inspiratory capacity equals tidal volume plus inspiratory reserve volume. It represents the maximum amount of air that can be inhaled after a normal expiration. Clinically, reduced inspiratory capacity is often one of the earliest findings in COPD. Patients frequently describe this as, "I cannot get enough air in." In reality, the problem is often that too much air is already trapped inside the lungs. Next is functional residual capacity, commonly abbreviated FRC. This is one of the most important concepts in respiratory physiology. Functional residual capacity equals expiratory reserve volume plus residual volume. In other words, it is the amount of air remaining inside the lungs after a normal passive expiration. FRC is approximately 2.5 liters in healthy adults. Think about what this means. At the end of every normal breath, you still have around 2.5 liters of air inside your lungs. Why is this important? Because FRC acts as an oxygen reservoir. Imagine if the lungs completely emptied after every breath, arterial oxygen would fluctuate dramatically. Instead, FRC buffers changes in oxygen and carbon dioxide, allowing relatively stable gas exchange between breaths. This concept concept becomes incredibly important during anesthesia and intubation. Obese patients, pregnant patients, and ARDS patients often have reduced FRC. Consequently, they desaturate much faster during apnea. Understanding FRC explains why pre-oxygenation is so critical before intubation. The next capacity is vital capacity. Vital capacity equals inspiratory reserve volume plus tidal volume plus expiratory reserve volume. It represents the maximum volume that can be exhaled after a maximal inspiration. Clinically, vital capacity is commonly reduced in restrictive lung diseases. A patient with pulmonary fibrosis may have a dramatically reduced vital capacity because stiff lungs simply cannot expand normally. Finally, total lung capacity. Total lung capacity represents the total amount of air the lungs can hold. Mathematically, TLC is equal to RV plus ARV plus tidal volume plus IRV. Or more simply, total lung capacity equals vital capacity plus residual volume. In healthy adults, it is approximately 6 liters. Now, let's connect this to disease. In COPD and emphysema, airway collapse during expiration causes air trapping. Residual volume increases, functional residual capacity increases, total lung capacity increases, the chest becomes hyperinflated. Patients develop the classic barrel chest appearance. Ironically, despite having larger lungs, they often ventilate poorly. In restrictive diseases such as pulmonary fibrosis, the opposite occurs. Lung expansion is limited. Almost every volume and capacity decreases. The lungs become smaller, stiffer, and more difficult to inflate. This difference forms the physiological basis for spirometry interpretation. Whenever you look at a spirometry report, an ICU ventilator, or a chest X-ray showing hyperinflation, remember that you are really looking at abnormalities in lung volumes and capacities. Understanding these numbers transforms respiratory physiology from memorization into clinical reasoning. In the next lecture, we will build on this foundation by discussing ventilation, physiological dead space, and work of breathing, concepts that determine whether a breath is actually useful or merely wasted effort.